Good evening and welcome to our webinar of the Royal Belgian Society of Dermatology. I'm very glad that so many people have enrolled, more than 200. I think that really shows how important our topic of tonight is. It is psychodermatology. And I'm very glad that we have been able to invite the best speakers from Belgium and of Europe for this webinar. And we are very glad that we have also industry support to make this happen, because it's quite an organization. We will speak about this later. So I would like to introduce Françoise Poot. She's professor for psychodermatology, and we don't really have to introduce you, Françoise, but you're the professor for psychodermatology at ULB. You also work at Erasmus and in Charleroi. You just founded an extra institute, the formation of healers. And so I think you are doing a lot of interesting things, but today you will tell us about compulsive behavior, mainly on the topic of trichotillomania.
Exactly.
Yeah. So we look forward to this. And then we have Professor Uwe Gieler with us. He came all the way from Gießen in Germany, almost from my hometown. I'm always very glad to see him. He is, I would say, the German leader of psychodermatology. And you will tell us about a real connection between emotions, stress, and the immune system and the impact on health. And Uwe Gieler is not only a dermatologist, but he's also a trained psychotherapist. The same is Ria Willemsen. Yeah? Ria comes from the UZ Brussels, so we work together very closely since many years, and I'm very thankful for this. And Ria and Elise Vandersichel, they will give a joint presentation on the difficult topic, what to do if the doctor doesn't find out what is wrong with me. So I think we have a lot of interesting topics, and it is very exciting to have psychodermatology now on the radar. And I would like to start with Françoise. And you will have some polling during Françoise's talk, and we will see the result in the end of the polling.
Welcome to this Zoom on trichotillomania, or pathological hair pulling. I think you know very well what it is. There will be a polling during this presentation to know a little bit if you see a lot of them, and to help you to retain some important information. So the sex ratio is 4:1 for female, and the prevalence in college students in the US, it's 0.5 till 2%. When you see this sort of patient with this hair, the first question to ask yourself is this self-provoked, or is it an alopecia areata, a diffuse one? So you take your dermatoscope and you look to the hair, and what you find? Broken hair with different shapes, coiled hair like this, you see, also flame hair, and a V sign like this, tulip hairs also, and a kind of hair powder with very short hairs. So it's trichotillomania, but is it hidden or denied? Sometimes, of course, at the beginning, patients are hide it for fear or shame or stigma, but very quick they will see that they do it themselves. Otherwise, we are in factitious disorders or malinjury. So we are now more, it's a body-focused repetitive behavior, and we are here in the compulsive spectrum, like acneic scoriae, onychophagia, also some scratching, and also some dermatotillomania, like they call that today. So, are there mental health problems, and even how to manage that? So to discover if there are mental health problems, first of all, ask some open questions and don't interrupt the patient. They will talk only for 2 minutes. How do you sleep? When do you pull? Why do you think it happens? they have often an explanation, and they can very well relate that to some stress even, or to some stress since a long time. You can also use the hospital anxiety and depression scale, where you have 10 questions on anxiety and 10 questions on depression. And this is very quick to fill in, and you will have a score. And if it's high in anxiety or in depression or both, it's the same. So the third question, very important question, is there suicidal ideation? This should be asked, and in a large sample from Brazil, trichotillomania was significantly associated with suicidal ideation and exposure to childhood sexual abuse. So what to do? How to manage? It's, first of all, you must know and be sure that it's protective to ask. They won't do it if they talk about it. The more dangerous when are not talking about it. They will say anything, no. So if there, then you should ask if there is a scenario ready. And it's rarely the case, but in case there is a scenario, then it's more dangerous, and you should try to create a safety net with some family members or some friends or some situation where they cannot do that, and transfer as possible to the psychiatrist. Are there medical treatment for this condition? There are glutamate modulators, including N-acetylcysteine and memantine. And this was evaluated in the management of trichotillomania, even in with blind control. And effectively, it happens, and it helps on the glutamate modulators. So if you discover, of course, clinical depression, you should propose antidepressant. I know it's not easy, but you can learn to use that. And if you are not used to it, I advise you to use sertraline 50 milligrams a day, because this is a very easy drug with a less side effect, and that is has a very short duration of action. So if you have to change, it's much more easy. But otherwise, of course, we should use psychological intervention by a psychologist, or also, but with some cognitive therapy that I will explain. Mindfulness, it's also helpful, hypnosis, and together with a psychiatric treatment if necessary. So I will talk about how to manage that in a dermatological consultation beyond medications. And this is first that you have to validate the feeling with active listening, showing empathy, acknowledging the feelings of guilt, despair, being unable to change, and knowing that there is an ambivalence because it helps them and it's a kind of pleasure. So even if it's hurting, and you should take the patient very seriously. And when you have this kind of listening, of course, you should have eye contact, start with open questions, let the patient talk, as I said, ask about the context, problem at school, family difficulties, heartbreaker, think about abuse, physical or sexual, you see that it's not rare, and accept relapses without angriness. So you should also, after some time, not at the first consultation, but ask them about this physical and sexual abuse. But don't say don't touch. It's not helpful. or it's your own fault, or be angry, or minimize, or ask the family to watch closely and say don't, except if the patient is asking it himself to be held. So there are different steps to change, and maybe your patient is not ready for a change. So be patient. They have to go to all these steps in the changing cycle: pre-contemplation, contemplation, preparation, and then action. Maintenance, but then there are relapse. And then again, you should start again the cycle. So work on the motivation, accept those relapses, and manage the guilt if it happens. It is normal, and it's not so a problem. So what is this habit reversal training that is easy to manage in a dermatological consultation? First of all, you should, of course, verify it's denied or not denied. And then you will also verify if there is suicidality or not. Otherwise, it's not in your hands. And then you look if there is a real motivation to change the behavior or not. If it's no motivation, you should try the motivation with the cycle of change. And if there is a motivation, then you can start with the habit reversal training, or try to send to the psychodermatology consultation, the psychiatry, or a psychotherapy. But you should be aware that it's not easy to transfer a patient. If you try to send the patient at the first time, they will not go to the psychologist. So they have established a relationship with you, they have shared some intimate feelings, and they want to continue with you. So you should explain, for example, that you will send them to a person you know very well, that is very kind, that you really know very well, and that, for example, you will give a call to this person to explain the situation. And in the time it's not possible, you can try, if there is motivation, of course, to manage the habit reversal training. So there are two different moments. There are pulling the hair, so unconsciously, or when there is an urge to manipulate, the patient tries to resist, but finally it fails, and then it's a release. But when they fail, they say, "Oh, it's not a problem. I did it, so I continue." But then it's the guilt, and the urge to manipulate comes again, because this is not a good feeling; it's a bad feeling. So we should use a combined approach for those two moments, and this is a self-help training with a very big importance of commitment for both patient and practitioners. And you should make a program of 4 appointments, if possible over 5 weeks. But personally, it's very difficult because my consultations are long, so they have higher price than a normal consultation, and it's difficult for patients to manage financially 4 appointments in the same month. You have here a website where this method is also well explained for atopic patients. So first of all, you give them a self-monitoring form that was published by the Massachusetts General Hospital, and it's a hair pulling scale. You will find that in the literature. And you should provide them or ask them to buy on internet a counter if they are pulling or scratching or excoriating a lot of time in the day. So if it's 300 times, they cannot use the file. But there are also other moments when they are in quite an auto-hypnosis time and they lose the notion of time. So they should use a timer. And I will explain that. So there are 4 blocks: the assessment, so you give, you explain, you give the counter and the table, and they should just observe and not do something else than they do usually. And then you look at the table and you give instruction. You should, of course, if there is adherence to what you propose, and there are 2 weeks of treatment, I will explain. Then you review it and you discuss again the adherence, the table, the counter, and again 2 weeks. And then a follow-up where you stop the counter, but you use the table, and you do one at 6 weeks, but also one at 6 months or earlier. So this is the table published in the International Journal of Trichology, the date and time, where were you, what were you doing, and if there are urge to pull 0 to 10, and the degree of awareness. If they find themselves with hair in their arm without having decided, like on the phone or in driving, then it's 0, of course. What are the notable feelings? And there are 2 movies that are very helpful for the children. You have vice versa, the first movie, and you have another movie that just appeared now. It's vice versa 2, where the feelings are well explained, and even for adults, they can recognize their feeling with that, because they are often not able to recognize their feelings, what is their thoughts, what is alexithymia. The sensation is more for itching or for pain or for burning sensation, and the strength of effort to resist, 0 to 10, and where they pull the hair, the eyebrows, the lashes, or the body, the pubic hair, for example. Then we give the instruction to replacing the behavior of pulling the hair, and when there is an urge to pulling the hair, then they should squeeze the fits for 30 seconds and breath, 5 seconds inhale, 5 seconds blocking, 5 seconds exhale, and twice. The inhale should be done with the belly, not with the chest. So you should explain that and give them the opportunity to try. And I have a little trick to be able to count seconds. They use crocodile, because to pronounce crocodile is the time for 1 second. So they think crocodile 1, crocodile 2, crocodile 3, crocodile 4, crocodile 5 in inhaling and with the belly. And then the same in blocking, and then the same in exhaling. So it's helpful because they cannot use a counter at this moment. If there is still urge, they can pinch or press the nail or another chosen object into the place. For example, with this stone where it's written, "Be your own refuge," it helps a lot the patient for different things, and they can press it where they want to pull the hair, and it's a bit cold also, and will remind them that they are in charge of their own salvation, for example, if I can say. So this is very helpful, but they can choose the object they like. And of course, there are difficult situations like in the bathroom, on the phone, watching TV, being bored, other situations with automatic behavior like driving. So for some, we can decide together to be quick. For example, for the shower, it's 5 minutes. It's much enough to take a shower and use a timer, because after they will be, for example, in the mirror or drying the hair, and they will lose the consciousness of time. They are in a kind of auto-hypnosis. And for the other situation, they can keep hands busy with a ball or with something to do. You can also decide that with the patient. At each appointment, of course, it's very important to look at the table, to discuss the thoughts and feelings, and of course, it helps them to explain different things that happen in their life, and it's very important. Keep the rapport and propose a mental health professional when it's appropriate. On the website of European Society for Dermatology and Psychiatry, ESDAP, we have the skin picking leaflet in most European languages, explaining what it is and that there is help to find. And if you want to be more able to help your patient, we have a psychodermatology diploma nowadays, and you can ask or send emails to know a bit more how it's organized. It's online, it's in English, and it's quite a bit of work. And there are 4 modules to follow in minimum 2 years or 4 years. Okay.
Thank you very much, Françoise. I think now many people will be interested in getting a psychodermatologist.
I hope so.
You clearly show that this is an art. May I ask you one question?
Yes.
Up to 2% in American college students. Are these numbers comparable to Belgium? I mean, these are very strong cases, severe cases that you show. I guess there are many, many more mild cases. Is this also up to 2% in our population?
I don't know exactly. I have no study on that. Maybe we should do one. But with the polling, maybe we have a little idea about it.
Yes, we were doing the mathematics from the questions that came, and we were at less than 1% when we see the answers from our dermatologists. So
yes.
Maybe that will be a master thesis in the future, if somebody's interested. Yeah.
Yes, yes. Exactly.
Thank you very much, Françoise. I think we now move on to Professor Gieler, and we look very much forward to your talk to learn about the cascade of emotion, stress, and the immune system on health.
Yes, thank you. So, hello everybody. I'm very happy to be here in Brussels and can talk a little bit about my special ideas and my special interest in the so-called psychoimmunology. And when you are sitting in front of a patient, many patients asking, is stress influencing my skin symptoms? And so it's a good idea to know a little bit about, and so we will see if it is true or if it is not that true, or is it scientifically proved. So emotion, stress and immune system at the skin symptoms, what is about. So I have some conflict of interest, but not for this topic. And I would like to show you very quickly where I'm coming from. So you see that from Belgium to Europe. And so this is my very old city, university city in the middle of Germany. And you see here, I'm working in a psychosomatic clinic. That means that I have about 50 patients every day, and about nearly half of them are dermatological patients. And so we see them for 6 weeks, so we know much about the lifetimes and the biography, and we are working with psychotherapy with those patients. And this is the clinical background I'm working on. But I would like to talk about 3 topics today. So what is about psychosocial comorbidities? So we have heard now that depression, anxiety, and suicidal ideation is always a problem in the general population, but especially and much more, significantly more in skin diseases. And we have to answer the question, how the emotions coming into the skin? And then this is the psychoimmunological pathway. And of course, I think you are also have an interest. Is there some psychosomatic counseling, what we just heard about trichotillomania, possible, and is it working? So let us start with the first question. Are there psychosocial comorbidities? You know, in the newer studies, it's always showing that anxiety and depression is there. And it's an old topic. When you see here the publication from 1942, it's very clear that always people and dermatologists are dealing with this topic. And coming from a psychodermatological point of view, we have the idea that we have the background theory of the so-called biopsychosocial theory behind. That means that, of course, we know that there are genes behind and there are personality behind every behavior and every possibility to come along with the life. But when you have a skin symptom, it quickly changes your ideas and quickly changes your coping behavior. We talked then here about the cumulative life course impairment. And of course, we have influencing from the social empowerment. We have influences from positive aspects, like we have resilience, we have resources, we have positive aspects of life that we can manage our life. But we have also negative influences, like traumatic aspects, or we have maybe compliance problems, we have attachment problems. And of course, they are more or less severe, and it is very clear correlation. If it is severe, then the influence is much higher than others. So let me talk about one example from a skin symptom. That means, let me talk about atopic dermatitis. So that means atopic dermatitis is well proved in a scientific way, and especially in the psychoimmunology pathway, we know nowadays much about how emotions and stress is coming into the skin. And when we are talking about the influences, of course, you know very well that we have many different influences in atopic dermatitis, and normally we are focused on the interleukins and the immunological pathways because we have very good drugs nowadays from the biologics and the small molecules which are working quite well. But now let us focus on one aspect that we talk about, neurogenic inflammation, because it's also there, and that means that psychoimmunology is working. And if you have a patient like this who is coming into the office and show you how many ointments, how many creams were used, then it's very clear now there is a problem, and a problem in the daily practice arise. Of course, it's always difficult with the hen-egg problem, and we have to discuss, is atopic dermatitis causes stress? So that means how is the coping behavior? Is the compliance well, or the adherence well, or not? Because it's necessary to deal with this chronic inflammatory skin disease all day life for the patient. So the whole week, the whole day, all the months, and all the year. We only see the patients maybe for 10 minutes in our offices every 3 months. And the other question is, maybe stress also causes the skin symptoms of atopic dermatitis. Of course, there are many papers on it, and so you see here a meta-analysis that very clearly show that there is an influence about the stress, that many studies show that stress is clearly influencing the atopic dermatitis. And of course, it's not only the patient, and this is the picture here from this baby that if you cannot read it, if I don't sleep, nobody sleeps, is here on the t-shirt of the baby. And that means that we have the so-called wider patients. This is a topic from Andrew Finlay, the author of the Dermatological Quality Life Index. And he is talking about the family influencing. And of course, families are also influenced. when we look at newer papers and recent papers, just this year, 2024, we have many papers, and so you see now, until now and until last week, it was at least nearly 90 papers about the topic atopic dermatitis and stress. And if I only pick out 2 papers which are highly interesting, means that there was a meta-analysis in 28 countries and showing that, for instance, the influence of quality of life is quite high, so more than 10, and that means that we are a very high influence of the dermatological life quality. And on the other hand, we have a clear higher odds ratios. That means a higher possibility to develop depression, to develop anxiety and suicidal ideation. So we would like to look about what is stress and what is coming when we have some stress. And if you ask the patients and yourself, everybody will tell there is a stress. But this is not a good question. The question must be, how is the stress? How often is stress? How severe is the stress? And how is it influencing really the skin symptoms or not? So this is a stimulating question, looking a little bit more. And in a psychodermatological point of view, we have to look about the different aspects of stress and stress behavior. And of course, we see here that it's in the example of atopic dermatitis, but you can put here any chronic inflammatory skin diseases, that we have problems with maybe traumata, and we have influences with depression, and we have influences with attachment and touch. And there are also some points behind. So for instance, we have difference in traumata. So we are speaking nowadays about violence, sexual traumata, traumatic experience, and emotional traumata. So we have different traumata which are influencing that. And people and patients who have more traumata have a much higher, significantly higher chance to develop a chronic skin disease, not only skin disease, of course, but also other chronic diseases like diabetes or other things. So, well, the depression are different. Is it a minor or moderate or severe depression? Is it a social phobia, or is it a general anxiety? We are looking in a psychodermatological point of view about, of course, stigmatization. How is the stigmatization feelings? It's especially in psoriasis highly important. And so we are coming now to the question, and I would like to offer you some aspects of the modern stress research. The stress research was there was a start in stress research from the well-known physiologist Hans Selye, which was a German physiologist, and he defined the stress very clearly, that stress is a non-specific response of a demand, whether it is caused or with the results of pleasant or unpleasant condition. So you see, this is very subjective, and this is very many psychological terms in the definition of stress, really. And of course, all of you know that we have different types of stress, and stress is not equal to stress. So for one person, the stress situation is not really there. For other patients, the stress in this situation is maybe very high. So this is the reality that we have to look for what is about stress and what is behind stress. Let us look a little bit deeper into the system, into the endocrine system. All of you know there is the endocrine system where stress is coming into the tissues. It's also in the skin tissue, of course, but also in other tissues the stress is working. And we have the endocrine reaction, and we have, of course, the adrenaline and noradrenaline pathway. But we have also the so-called neuropeptides and the neurogenic and the neurogenic inflammation pathway, and maybe also a fourth column, which means that we have maybe also acetylcholine as a pathway coming into the stress. And if you have stress, so this is the regulation that maybe you see that maybe this column is more active or this color is more active. And so this is the influence that the system is coming on, and we have to look what has happened there. We look about atopic dermatitis, and first of all we start with the scientific examinations of mice which are developing normally genetically atopic dermatitis. And if you made stress to these mice, it's very clear, so with noises for instance, that they will react. And they have a much higher, significantly higher mast cell degranulation, for instance, in the skin. And we see that also there is a stress reaction, and in these mice that means if the mice have the genetic disposition of atopic dermatitis together with stress, then the result is the highest column. On the other hand, if you have these mice and you give these mice a stress situation, always in comparison to normal mice, then you see we can stop also the stress reaction giving a blocker, so an antibody of neuropeptides, in this case nerve growth factor antibodies. So we can say in mice, it's very clear, the studies show there is a very clear influence from stress in atopic mice. Of course, mice are not humans, so we have to go ahead, and there is a stress test, which is called triad social stress test. That means giving a speech in front of people, so which is not easy. Normally it comes to stress and the cortisol pulse and tension is going up and high. So this is the stress situation for humans. And when we are looking in the blood, then we see easily that here you see there is a difference in the atopic dermatitis patients in comparison to the healthy controls, that here the brain-derived nerve factor, so another neuropeptide, is different to those who have not an atopic dermatitis. So atopic dermatitis patients react in a different way in comparison to normal people. Of course, this is in the blood and this is not in the skin. And then finally, my working group and my team decided to make a real stress experiment in the skin and look into the biopsies. And so we convinced our ethical committee that we can take biopsies from patients with atopic dermatitis in healthy controls and look into the skin really and into the molecular basic of the stress reactions. And this was the result. Just quickly, there are clearly also in the skin, in the different cells and in the different reactions, we have different reactions of neuropeptides in the skin in this stress situation. And this was published, and we are not the only team who showed such results. There were other teams in the world as well. So we can say today that stress is really reacting also on a molecular basic in, for instance, atopic dermatitis. That means that the brain and the skin is coming together, and we have, on the one hand, we have an adaptation in the endocrine system when we have stress. This is a good idea because then we have chronic stress sometimes, and our endocrine system will adapt to this system. But on the other hand, we have the neurogenic inflammation system, and this is not that well with the adaptation. So this adapted not that good in the chronic stress situation. And we know very well that we have these nerve endings in the skin. So you see here this so-called polyclonal C fibers in the epidermis and have contact here with the dendritic cells and the T lymphocytes and so on. So, and this is electronic microscope picture showing that there is a very clear connection with nerve synapses and the T lymphocyte in the epidermis, and the reality is looking like that. So you see here so many nerve endings are in the epidermis. So we have normally 50 in a square centimeter polyclonal C fibers which are acting and influencing really also the inflammation system. So we can finally say that atopic dermatitis is also not only interleukin inflammation, but also a neurogenic inflammation disorder, which is influencing in stress. So you have to look with the patients what is about the stress. And to summarize that, so maybe you have a situation, there is a problem in this couple, and they fight against each other every day. And so it's now very clear the brain will react. The brain is working. We see that we have a neurogenic inflammation system coming into the skin and have contact to the dendritic cells and T lymphocytes. And these T lymphocytes are going ahead and making also more inflammation. And then the vicious circle is closed. And this couple is now, when one of them has atopic dermatitis or psoriasis or whatever, then we have a very clear reaction on that. And so we can go ahead now. What is about therapy? Of course, we can use the new drugs with biologics or small molecules in this pathway, so between the neurogenic inflammation and the reaction into the symptoms. And we can stop it to block the antibodies of interleukin. But we can also use the other older drugs which are stopping this system. But we can go also in psychodermatology, and we can here give relaxation training or mindfulness training, maybe hypnosis, that to stop this pathway from the brain into the skin, because relaxation is here helpful. Or maybe also the best way is to talk with the patients and making psychotherapy, hand over some information how to talk and how to do it, that the fight is a little bit lower, and maybe then the symptoms are decreasing. So, and there's also a decision possible that we can combine the symptoms and these therapy options we can combine. So just some 1-2 minutes about therapy. And I will announce, especially in atopic dermatitis, the atopic dermatitis psychoeducation program, which is nowadays worldwide accepted and coming up from this very early paper in 2007, where we offer the psychodermatological aspects in atopic dermatitis. And nowadays, in every guideline in the world, you can see that normally also the educational programs is the basic therapy for dealing with atopic dermatitis. And this means that it is a very clear psychodermatological aspect, because it's more psychological aspects and relaxation training, and not only dermatological information. In Germany, we have the system with some special age groups. So if we have small children with atopic dermatitis, we are educated the parents in 8 to 12 years old children, the parents and the children coming to groups, but different groups, the children group and the parents group, in the youth without parents, and in the adults also without parents. And the system is, for instance, here in Germany, we have a 6-session education program, which is also paid by the insurance companies, luckily. And so this is a system that we have different topics, so dermatological topics, nutrition, but many topics in psychodermatology. So it's a clear structured group program with specialized trainers, and a multimodal program, which means not a face-to-face education, but in groups. They can have an exchange together. It's not a self-help group, because there are specialized trainers who are leading the groups. And it's also focused on the didactic and the psychological aspects, not only the medicine, and that what we are calling patient empowerment. And the background that we have it in all guidelines in the world is there are so many now randomized controlled studies with education programs which showing that we have a very clear aspect that this randomized controlled studies showing that this counseling program for atopic dermatitis is working well, and also recent papers showing that. But of course, we have other aspects. We have heard it already for trichotillomania, that we have some meta-analysis. So 8 types of intervention were tested, and they show some efficacy, that different psychotherapies are working. Of course, here the science is not high. We have to move on, and we need more studies about that. But just one example here again, you heard already about the high habit reversal training programs in trichotillomania. It's also working in chronic inflammatory skin diseases like atopic dermatitis. Here, one of the very good studies showing that together with habit reversal trainings, we have a good idea. And if you have behavior training, you see here one study, the curves here are very equal to those curves you know from the drug research in the biologics and JAK inhibitors. And here, but these are the result from behavior therapy giving in an internet program. So hopefully you have some ideas about the background that stress, emotions, and skin is coming together. And so I thank you for listening. And if you are able to join us and have more interest in these topics, you are highly invited to come to our World Congress next year in Istanbul. Thank you very much.
We have applause in the room here, I'm sure, but we cannot hear it from outside. I was wondering, I think you made pretty clear that there is a holistic approach necessary, that we need to address the psychodermatology, that we have these ways to intervene, and we have the medical treatments. How powerful is, if you would think in SCORAT reduction or EASE reduction, if we only use things like mindfulness and relaxation techniques, how much is the potential here, the effect size?
Yes, I always say that psychotherapy is not the only or the solution that will reduce symptoms. But in the example of the education programs, we thought that we can increase the coping system for the patients, and we can increase the social anxieties and social behavior. But we were wondering that really also the severity with SCORAT was decreased. And so this was a good thing in it, and it's also repeated in other studies and also in the economic pathway. And you are absolutely correct. We have to deal with human beings and who have skin symptoms. And that means we know evidence-based medicine. We know which is maybe the best drug, the best treatment option. But we have to deliver it. And we have to look for the patients, which is the coping system of the patient, and which is the psychological background of the patient, that we have a good shared decision making and that we have a good adherence, at least. That the best treatment we thought, is also took over, and we have seen the program from Françoise, which showed that the patient decided what to do, and we can offer it, and so, but we must come to the shared decision making, and there is many psychological influences in it, of course.
Thank you. We have. This is not for here. Yeah, the questions for. So thank you very much, Uwe. I think there would be many more questions, but we move on. For the sake of time, we promised to stay in time. So we now come to our third presentation by Elise Vandersichel and Maria Willemsen. And as I said, you guys are really now our duo in psychodermatology.
We will share our presentation.
So the word is up to you.
Thank you. Okay, I think, we will talk about difficult patients. So sometimes we really don't know what we have to do with the patient. For instance, look at this first patient. Can this slide a little bit bigger? I don't know, see it's so minimal? Yeah. Okay, it's not, okay, thank you very much. So I give you an example. This is a woman of 63 years old with a distressing pruritus on the scalp. Already there since 5 years, and more intense in periods of inactivity when she wants to sleep or is sitting before the TV. She has seen several dermatologists as well as neurologists, but all investigations were negative. She's very anxious about this health concern. She has an impaired quality of life, it gives her stress, and she starts to say, I don't want to see any people anymore. So in this kind of case, you have to consider a somatic symptom disorder, which is the new name for what we used to call somatization. It is mainly a preoccupation with one or more distressing symptoms, and we see that often in dermatology. And although the older names are still used, you see them in the slide, most authors suggest now that the best name is somatic symptom disorder. There are 3 official criteria. Patients must have one or more somatic symptoms. They must have doubts, feeling, and a lot of anxiety related to that problem. And the symptoms must be more than 6 months. And we know in all disciplines of medicine that unexplained symptoms, that 1/3 of the symptoms are unexplained by a known disease. I always thought you were alone in dermatology, but this is occurring in all disciplines. And we received this slide from one of our psychiatrists who in our clinic did an interesting workshop on this topic. And in some patients, these unexplained symptoms, they can persist and they can be very stressful for the patient. And I give you here the list of the most commonly occurring persistent unexplained symptoms. And you see they are very general and not only for dermatology. For dermatology, we know them all, very difficult patients with that kind of symptoms. They are in red. And often these patients are treated by different disciplines, by different specialists. It makes their treatment fragmented, which is not a good thing. And there has been a move to put those particular affections also in this group of somatic symptom disorders. You might know most of them, and you see for dermatology, again in red, you see the most pain syndromes are there, also some itch syndromes. And we also have the multiple chemical sensitivity syndrome, and people who have this, they have a cluster of non-specific complaints which they attribute to symptoms, to chemicals, little dosages of chemicals in their surroundings. There are some characteristics. Symptoms, they occur in clusters, for instance. We see often chronic pruritus together with localized skin tingling and a chronic back pain. And since I know this, I often see this in my practice. Fatigue, pain, and sleep problems are often associated with the other problems. And often there is also anxiety and depression. And you can imagine that for those patients, there is an enormous impairment of quality of life. They often are not able to work. And one of the reasons there is so much research going on is that they present a high cost for society as well for the healthcare. And current research focuses on this stress model. There are predisposing factors, and we know that early life experience, such as child abuse, you heard already from Uwe Gieler on that, but it's also a very important predisposing factors. There are triggering factors. Often a triggering factor is a combination of an intervention or an acute disease together with a stressful life event on the same time. Maintaining factors are also important. Patients have too much attention for their symptoms and they start to change their behavior. And the actual concept, and that's very important because this is a change compared to before, that any physical symptom can lead to persistent symptoms. Even a somatic disease with a clear cause and a good treatment can lead to persistent symptoms. For instance, as a dermatologist, you treat an atopic dermatitis, the disease is going well, you have given a good treatment, but minimal itch can persist and can be very stressful for the patients. And that's what we often see in dermatology. And one of the reasons for this is, and I found this very interesting to read, is that research has shown that symptoms are imprecise interpretation of body states. We think that what we feel is the truth, but that's not so, because the interpretation by the brain of the body states is highly dependent from past experience related to that symptom, and also from the beliefs, the interpretations, and the expectations of the patient, because that's exactly how nocebo and placebo effects work. And that means that it's not objective. And one of the reasons for this, also very interesting, I think, is the phenomenon of brain central sensitization. And brain central sensitization is already a long time known in the research of chronic pain. But it also seems to play an important role in itch, for instance. And it means you can compare this with an overactive sound system leading to disturbing noises. But in our practice, it means that the brain becomes too sensitive to signals from the body. There is an overactivation of the itch brain pathways, and there is an exaggerated interpretation of the brain from signals of the body. So what can you do? You start with a good communication, but this is not a good communication. I hope you can read it, yeah. So a doctor can say, I have good news, you have nothing. But the patient says, I'm not cured. They don't believe you, and it has been proven also by studies that it makes the symptoms worse. So there are other rules. There are other good communication schemes. So for instance, this, and there are proofs of it. Elise will go further on that, but that's already what I can tell about it. In the first step, you have to believe the patient. They really feel the pain, they really feel the itch. But you can tell them that symptoms are not the same as disease. Then you can ask them to stop looking for causes or miraculous treatments, because the reason is multifactorial and may vary between individuals with the same symptoms. Ask them to look for those different factors, which you can already overview with them. And maybe you can also explain them the vicious circle between symptoms on one hand and anxiety and stress on the other hand. I often also explain the central brain sensitization, and for this I use, for instance, this YouTube movie. There are also some in Flemish by a Dutch GP organization. So I give now the word to Elise.
Thank you. So I will highlight a little bit more about the treatment. The goal when treating these patients with a complex pathology is to reduce the severity of their somatic symptoms. So this improvement of symptoms will lead to a quality of life and well-being increase. And it's important to simultaneously launch the physiological and the psychological treatment. So it's not an either or, it's really important to do both and to pay a lot of attention to both of them. If there's any diagnosis-specific treatment available, for example, for our atopic dermatitis patients, of course, we will also try our best to treat the eczema and to manage the symptoms the best way we can. And we'll try to focus on the patients and giving a lot of recognition, validation, and do an appropriate way of communication. And as Ria explained, and as Françoise explained, we will definitely not say it's nothing, and we will avoid all kinds of nocebo effects in this way. I will focus a little bit more about the psychological and the pharmacological interventions. So there's quite limited evidence about which therapy might work best, but there is some significance in it, and I will highlight the cognitive behavioral therapy, and this is one of the many available therapies. This is a Norwegian model, so maybe we think cognitive behavior therapy, this is not something we will do in dermatology, but there are some really interesting points in this model. It's actually a general practitioner model that was performed in Norwegian and also in Norway, and also in Great Britain there's a parallel study, and they looked at how they talk to the patient, and the goal was to improve the problem-solving skills of the patient by talking about what are the problems that they face. For example, if a patient comes to the general practitioner or to the doctor and they believe that they cannot work, to really talk about why do they believe they cannot work, and maybe there are alternative options and there are alternative solutions, and also to realize which ones are most suitable. There is the importance of behavioral activation, so shift the focus of the patient to what they cannot do and try to look at what are opportunities. So it's a dead end to keep focusing on what the patient can do, and they have been struggling for a long time. It might be eye-opening to focus together on some opportunities. By asking open questions with difficult work, Socratic dialogue, but really it's open question asking to facilitate the patient and to think about these topics. And this will lead the patient to a more realistic and helpful thinking pattern. So instead of I cannot do this, I cannot do that, and I cannot work, to try and find things that are available to the patient. It's really helpful to make the patient think about it at home so that they really come up with these ideas and solutions themselves, and to talk it through together. So these steps can also be helpful in our dermatology practice. For example, not to focus too deeply on, no, we will do more tests, or we cannot find anything in the test, and to really shift towards what can we do with the patients, how can we work together. There are also pharmacological interventions possible. So there are some studies that compare psychopharmaca to placebo, and some of them have actually quite a lot of effect. This is the case in dermatology, but also in, for example, irritable bowel syndrome or in chronic pains. There are several classes of antidepressants that have their added benefits. Our advice would be to work with one of them and to really learn some of the medication. It might not be easy as a dermatologist to prescribe an antidepressant, but it's really helpful if you're able to do it. And the SSRIs, for example, as Françoise also mentioned, sertraline is quite accessible, and we advise to learn how to work with one of them. The doses that we're given are quite low doses for adverse events. As we saw before, these diseases have a lot of comorbid depression and anxiety, and this is an additional benefit in the treatment with antidepressants. So we thank you for your attention, and we hope that we were able to provide some insight in these somatic symptom disorders. Thank you.
Yeah. Thank you very much, you both. I'm checking. We have an update on questions. There's no update on questions. I really learned a lot from you tonight. First of all, psychodermatology is an art. I think that is what I see from all the three presentations, how diligent you have to act, how you have to feel, and how you have to interact with the patients. That is really an art, and we are quite glad that we have you. You are reducing our stress. I will come to that. I learned about the central brain sensitization, and I had a patient like this afternoon, itch and this tingling sensations in the legs.
Back pain. Often they have chronic back pain.
Yeah. And she had pain too, yes. But now I realized the connection of both, and
pain too. Pain. Vulvodynia, painodynia. It's the same sensitization. It's other fibers, but it's really the same process.
It's interesting that they put everything together now in the same.
It's really the same process.
That was really an eye-opener, so she will come to you very soon. Yes, I think we are at the end of our time, so Are there any questions among the group? Anything somebody would like to ask?
Yes, I had a question to Françoise.
Yeah.
You mentioned L-acetylcysteine. I tried it a few times.
No results.
No, and I know dermatologists they prescribe it, and some people like it, but psychodermatologists.
I don't. But it's in the literature. It's in the literature,
and it's always mentioned in the literature and in the papers. I have the same experience like you.
But
so
no,
I would not recommend it
not too
that much.
but
it's not a drug. It's an additional nutrition aspect. So this we have to keep in mind. So it's not really a drug.
Also, now we know better how it can act on the glutamate system, and it seems that it's really a good reason and a good pathway, but it doesn't give so much effect. But if someone
some people like
really wants to try, yes, it's not dangerous. It's a bit expensive. It's a lot for the. It's a lot of boxes. So, but if they want to try, why not? But not just that, because it will not work.
Okay,
you should do the rest.
So we still agree on the same.
Yes, on the same.
Right, And so I would like to add that it's a good question from you, Jan. That the difference between psychodermatologists and normal dermatologists for me is dermatologists have good ideas and have evidence-based medicine and think, so this is the symptom and we have to treat the symptom and I have the best treatment for this symptom. This is a good idea, of course, but the psychodermatology aspect is to see this point, but to see all the influences. So we must wider the brain and wider the aspect. That needs a little bit time, but I have also the sentence, you have always the time you have. And even if you have only short time, you can give a good communication instead of a bad communication in your time you have. And so this is I think this is the best idea for all the dermatologists.
I think that we really have to take with us. That's always, I think, without communication, the patient will never do what we want him to do. I absolutely agree. So it's time to thank, first of all, our first speakers, Françoise, Elise, Ria, Uwe. Thank you very much for coming here, taking your time. It was raining, it was snowing, but everybody was there on time, so we were very glad and that it worked out. And there was a lot of organization behind this evening. So we had from the Royal Belgian Society, we had Gaël van der Werve, Jennifer Robinson, Karin Flemings, Veronique de Marmol. They have been working hard behind the scenes. Thank you all for this effort. And then also here the studio crew in Zaventem, we are with on screen, and I think they really surround us very well and tell us what to do and when and make sure that it works out. And finally, our sponsors, because with our significant support, such a webinar is not possible. It is unbelievable how much technology is in this room that you do not see that is necessary to make such an evening possible. And finally, thank you to our audience. Thank you to the Belgian dermatologists. I think that more than 1/3 are present tonight. I think that's a fantastic number. Thank you very much. And do not forget to mark your calendar for the 27th and 28th of March 2025. That's our Belgian dermatologists. It's 125 years of Belgian dermatology. I think we have made a great program at the best location in the country, next to the Grand Place. Everybody can come by train. And so we hope to see you all there to enjoy 2 great days of dermatology. And now I would like everybody to enjoy his evening. Thank you very much. Bye-bye.
you.